Dear Marolings, welcome to this session where we are going to talk about the Psychiatry NEET-PG 2024 Session 1 questions. Let's jump into the first question. A patient comes with complaints of difficulty falling asleep. The person has the habit of taking black coffee about an hour before going to bed, which looks like not a great idea if they want to sleep. What is the role of caffeine in wakefulness is the question they've asked. So to answer this question, one, you should know about caffeine, or you should know about adenosine, or you should know the relationship between caffeine and adenosine. So what's the answer for this question? Anybody who has listened to the videos would be able to answer. Caffeine inhibits the adenosine receptors and thus leading to awakening, increased attention or awakening, or decreased or increased arousal can happen. Understood? Now, let's understand few interesting things related to this question. First of all, let us understand what should you know about adenosine. What should you know about adenosine? When you talk about adenosine, please understand, at the beginning of the day, adenosine accumulation will be very less. As the day goes on, adenosine will start getting accumulated more and more in the basal forebrain area. In the basal forebrain area, the adenosine starts getting accumulated as the day goes on and you keep on using your cognitive functioning and brain functioning. This basal forebrain area adenosine accumulation is the one which increases lethargy, increases fatigue, and ultimately it increases drowsiness or sleepiness, ultimately making you sleep. Now that is the reason, as day goes on, as you have been active through the day, slowly as the evening and the night approaches, you start becoming tired and sleepy. What happens with caffeine? When you take a cup of coffee or tea which has caffeine, what happens is it blocks adenosine receptors. It blocks adenosine receptors. Especially what is important here for caffeine is adenosine 1 receptors and adenosine 2A receptors. Adenosine 1 receptors and adenosine 2A receptors are blocked. By blocking these adenosine receptors, it increases arousal, it increases attention, it can increase focus briefly. That is the reason sometimes we end up drinking tea, coffee a lot just before our exams. But you need to be careful that if you go more than 3 cups a day, especially strong cups of tea or coffee, you might tend to have caffeine toxicity, which can make you become very anxious, panicky, restless, having headache and those. So some amount of coffee can be used suitably. The best thing which is advised, especially people who have sensitive to bad sleep when they drink coffee late night, is not to drink tea or coffee after 4:30 in the evening, so that it doesn't affect the night sleep, and it is a good sleep hygiene practice to follow. Getting to the next question, which of the following SNRI is used in the treatment of ADHD? Which of the following SNRI is used in the treatment of ADHD? What is SNRI? We are talking about selective norepinephrine reuptake inhibitor. Understood? Which of the following is a SNRI? Answer for this question is reboxetine. Actually speaking, ideally, if the examiner wanted to ask, they should have given atomoxetine, which is much better, because reboxetine slowly is moved out of practice and very rarely it's available in India. So a lot of people are prescribed atomoxetine. So that might have been a better choice to be given. But whatever is given is given. So please remember, reboxetine or atomoxetine are some of the important SNRIs which you should remember. Are those the only ones? Let's understand a little bit more about managing ADHD, because that's something which is asked in exams. If you're talking about managing ADHD with medications, with medications. There are two important classes of medications. One are called as stimulants. One are called as stimulants. The other one are called as non-stimulants. Understood? Stimulants are generally more effective, but at the same time, they have little more addictive potential. Because they are a stimulant, they have some amount of addictive potential. In patients with history of addiction to various substances, you should be a little careful about giving stimulants. In those patients, maybe you would prefer to use non-stimulants. When you're talking about stimulants, in our country, the only one which is available is methylphenidate. The other stimulants are something of amphetamine salts. What kind of amphetamine salts? Lisdex amphetamine, dextramphetamine are important ones for us to remember. Understood? So, among stimulants, if they ask you, is methylphenidate or amphetamine salts, which is better? So, obviously, amphetamine salts are much, much better. But again, they also have more addictive potential compared to methylphenidate. Methylphenidate is a stimulant. But is it an amphetamine salt? No. Methylphenidate is not an amphetamine salt. It is a blocker of norepinephrine and dopamine reuptake. Methylphenidate is a norepinephrine and dopamine blocker. Amphetamines also do same things, but one more important thing they do is they increase release of dopamine. They increase the release of dopamine. This one factor is what makes it more addictive potential. More addictive potential, the increase in dopamine. So please remember, we have the stimulants. In stimulants, what's available in our country is methylphenidate, which is not a amphetamine salt, but it is a dopamine or a norepinephrine blockade kind of a substance. It increases indirectly by blocking the reuptake, it increases the dopamine and the norepinephrine levels. Amphetamine salts are even more effective but also addictive. Lisdexamphetamine and dextramphetamine comes here. So what about the non-stimulants? When you're talking about the non-stimulants, here you have the SNRIs. What are the SNRIs you should remember? The most important one is atomoxetine. The lesser known is reboxetine, but it is not FDA approved. Reboxetine is actually not FDA approved, so lesser used. The other FDA approved drug is called as viloxazine. Understood? What are the other FDA approved drugs? You know, they are not SNRIs, but they belong to another class. What are they called as? They are called as alpha 2 agonists. The two important alpha 2 agonists are clonidine and guanfacine. Clonidine and guanfacine are alpha 2 agonists, which are non-stimulant kind of drugs which are used in ADHD. So let's summarize once more. For ADHD, you have the stimulants and the non-stimulants. In the stimulants, in India, we have methylphenidate alone. Otherwise, you have the amphetamine salts like lisdexamphetamine and dextramphetamine. Whereas when you're talking about the non-stimulants, we are talking about drugs like SNRIs, which are atomoxetine, and viloxazine, which is a newer drug. Then you have the alpha 2 agonists, which are clonidine and guanfacine. That's something which you should know. They can ask any of these questions. A 45-year-old woman presents with feeling of nervousness, abdominal pain, diarrhea, heartburn, indigestion for 25 years. Similar complaints in family of being tense and nervous. So there is family history of some kind of an anxiety kind of reaction. What else symptoms do you expect in this patient? So when you read this question, you're wondering, sir, what are they asking here? I haven't read something like this in any of the MCQs earlier. Please remember, they are giving all kinds of anxiety symptoms. They are giving all kinds of anxiety symptoms, or what we call as neurotic symptoms. All kinds of anxiety symptoms are neurotic symptoms. And then they are asking, what else will be seen here? Hallucinations, ideas of reference, neologism, and tingling of extremities. Please remember, the correct answer for this question is tingling of extremities. This is what can be expected. Some kind of paresthesia. Some kind of paresthesia can be expected in patients with severe anxiety, stress reaction. They can have these kind of things. Ideally speaking, neologism, not necessarily ideas of reference, but when you're talking about delusions of reference, especially, these are typically seen in psychotic patients. In psychotic patients. When we initially spoke about psychiatry, right, in the videos, we did speak about psychiatric illness being divided into two main types. What are the two main types of psychiatric illnesses? One is the neurotic illness, the other one is the psychotic illness. How do you differentiate neurotic illness from psychotic illness? If you can recall, judgment, insight, personality, and reality contact. Judgment, insight, personality, and reality contact, right? These were the four main domains you look for. These are typically preserved in neurotics, whereas these are typically absent or reduced in psychosis. Getting it? So, best example for psychotic illness could be schizophrenia or delusional disorder. A good example for neurotic condition could be something like OCD, generalized anxiety disorder, panic disorder, those kind of conditions. Now, when you look at this interesting question, what you should know is this a very common kind of psychiatric issues which we see. In lot of specialties, if you see, if there are 100 patients in the OPD sitting and waiting to meet the specialists, maybe a cardiologist, maybe a gastroenterologist, if there are 100 patients sitting in a specialty OPD, almost 20 to 30% of them might actually have somatic complaints, somatic symptoms and somatic complaints, which are mostly going to have some kind of psychological reason or underpinning. So almost 20 to 30% of any of the medical OPDs or specialty OPDs could be psychiatric patients who are not coming to a psychiatrist but going with physical complaints to these patients. So if you can identify the patients and say, see, it's because of your stress reaction, it's because of your anxiety, they can get better care and help at the earliest in managing their anxieties and stress. So one of the common things is generalized anxiety disorder patients can have a lot of bowel bladder disturbances, and you would have heard of this condition called irritable bowel syndrome, right? Irritable bowel syndrome patients very commonly are known to have comorbid anxieties, and possibly this is one of the conditions which is being described in this MCQ. Going to the next question, an interesting one. An alcoholic patient presented to emergency in an unconscious state. Relatives state that he had a binge episode of drinking about a week back. On examination, his glucose is 49 milligrams per deciliter. What is the appropriate management? So, they haven't asked the typical alcohol withdrawal related benzodiazepine kind of question, which is commonly coming. Now, this time they've asked something where they've given the glucose levels are very low. So, the patient is having hypoglycemia. Patient is having hypoglycemia with the background of alcohol use and recent withdrawal. So what do you give treatment? Do you give dextrose directly? Do you give thiamine and dextrose? Do you give saline? Do you give vitamin K injection? What is the answer? Most of the students would have started reading biochemistry. Forget about coming to clinical subjects. When you're reading biochemistry, you would have learned this important point that thiamine should always be given first before you give dextrose infusion, especially in chronic alcoholics, because there you are suspecting thiamine deficiency, and this thiamine deficiency can lead to what? It can precipitate Wernicke's encephalopathy. It can precipitate Wernicke's encephalopathy. So if you don't want that to happen, you want to give thiamine first. So if you apply that logic here, you should give T, D. Yes, you'd have heard, right? When you're making a lot of money, one of the important things you pay to government is called as TDS, tax deducted at source. So please remember, in these conditions, thiamine should be given first. Dextrose obviously should be given next. Then saline might not be necessary in all patients if there is significant dehydration or electrolyte imbalance. Depending on that, saline solution can be thought about depending on what is the issue. But please remember, thiamine number 1, dextrose should be number 2. That is what has been tested in this MCQ. Now, alcohol withdrawal drug of choice obviously is benzodiazepines, right? What is alcohol withdrawal drug of choice? Benzodiazepines. When you want to treat alcohol withdrawal, you want to give benzodiazepines. In that also, you should remember, in patients with liver dysfunction, what are the ones which are preferred? LOT. LOT. Lorazepam is preferred. Oxazepam is preferred. Temazepam is preferred. Understood? Lorazepam, oxazepam, and temazepam are the preferred benzodiazepines in patients with liver dysfunction or elderly patients. In liver dysfunction patients or elderly patients, you would prefer these three. Otherwise, any benzodiazepine can be considered. With this, we come to end of the session 1 questions. Dear Marrowlings, in this session, where we are going to talk about Psychiatry NEET-PG 2024 questions from the session 2, let's jump into the first question. A 19-year-old girl comes agitated to the department, emergency department, with previous history of suicidal tendencies, and parents do not know the mode of drug administration, but she presents with tachycardia, tachypnea, diaphoresis, and dilated pupil. Dilated pupil. What is the likely diagnosis? Now, you might have discussed this in medicine or your pharmacology or your forensic medicine too. What you need to know here is they are talking about some kind of a stimulant medication. They're talking about some kind of a stimulant medication. So the answer here obviously is cocaine. The answer here is obviously cocaine. In morphine and heroin, what kind of pupil do you see? You see pinpoint pupil. You see pinpoint pupil. And moreover, you will see respiratory depression. And again, these patients also are in coma. Understood? They are in coma. Now, that is how the triad of morphine and heroin patients come. So the answer for this question is cocaine. Chlorpheniramine is nothing but a antihistaminic drug. Antihistaminic drug. Understood? Now, what is interesting for you to know is morphine and heroin have kind of a link. What is the link? Heroin is nothing but diacetyl morphine. Diacetyl morphine is what is called as heroin. Understood? That's something which we should know. By just adding 2 acetyl molecules to morphine, what has happened is heroin is known to have increased lipid solubility. It is known to have increased lipid solubility. So it is known to be more addictive, more faster action. And of course, heroin is illegal, whereas Morphine has medical license approval, right? In a lot of medical conditions also, they use morphine. So these are some interesting points you could know in relation to this MCQ. The MCQ was straightforward. Anybody who has read some basic autonomic nervous system would have answered it. Cocaine, being a stimulant, is known to cause tachycardia, tachypnea, diaphoresis, and dilated pupil, whereas morphine and heroin are typically ones which can cause pinpoint pupil. The next interesting question is, a girl was referred to psychiatry department by the plastic surgeon. She had visited multiple plastic surgeons requesting full facial reconstruction. She complains of dark blemishes and spots in her faces, which are not actually present. She always says that she is ugly and looks constantly in the mirror and at the back of the spoon and windows. Oh, back of the spoon and windows. That's quite interesting. Her mother assured her that no such issues are there. So, other people around her are not noticing any challenges, but this person is too worried about dark eyes, and kind of skin blemishes which are there, and asking repeatedly to various plastic surgeons, asking them to do some surgery. So, what do you do is the question. What would you like to diagnose here? The condition we are talking about is called as BDD. What is BDD? BDD is nothing but body dysmorphic disorder. Understood? Body dysmorphic disorder. It is also called as dysmorphophobia. Now, the question what they have asked here is, what do you want to do? Do you want to give an SSRI? Do you want to give fitness for surgery? Do you want to give atypical antipsychotics? Or do you want to kind of do insight oriented psychotherapy? Insight oriented psychotherapy. See, if you look at this question, you know one thing. The diagnosis we are talking about is body dysmorphic disorder, and any condition where there is constant preoccupation or constant obsession with something, SSRIs are the treatment of choice. Whether it is OCD or body dysmorphic disorder, SSRIs remain the treatment of choice. The interesting caveat here you should remember is, in these patients, the patients can have ideas. Body dysmorphic disorder patients can have ideas. Ideas means they feel maybe my face is having these lesions, or maybe my ears are bigger, maybe when the nose is crooked. They have a doubt. Then it is called as ideas. They can sometimes go on to have what we call as delusions. What do you mean by delusions? Delusions are false fixed beliefs. False fixed beliefs. So, what happens in false fixed belief? In false fixed beliefs, delusions can happen. Understood? So, here they are fixated so much that, like in this question, you give multiple plastic surgeons have told no, then also the person is not able. Mother is saying no, the person is not able to agree. Nobody is able to see any problem, but the person is not able to agree or is willing. So it is almost a delusional level. So some of the students could be tempted to put, sir, if there is delusion, is this not the answer? Please understand, as per guidelines, in body dysmorphic disorder or even OCD, even if the patients have very poor insight or almost delusional level of thinking, the first choice always remains SSRIs. You can add on antipsychotics at small dosages, but primary treatment in these kind of obsessive preoccupation kind of thinking is SSRIs, like illness anxiety disorder, where the patient is preoccupied about illness, obsessive compulsive disorder, or hoarding disorder. In all of those conditions, we are mostly considering SSRI as the number one choice. So the answer for this question would be SSRI, even though some students could be tempted to think of maybe a delusion is there, so the patient should be taking atypical antipsychotics. It is actually noticed that when you give SSRIs, the preoccupation comes down, the delusional quality slowly starts breaking. Of course, sometimes in some patients, they do require additional typical antipsychotics, but what is the primary treatment? SSRIs is the primary treatment for body dysmorphic disorder. The next question is, a girl presented with multiple episodes of loss of consciousness The episodes usually happen in the presence of family members or known people and in the morning hours, not nocturnal, not during sleep, but morning hours. She regains consciousness after 15 to 30 minutes and usually remembers the events during the episode. So there is no amnesia. There is no amnesia in this history. Okay? There is no tongue bite. There is no incontinence. So all of these are suggesting the patient is possibly having some kind of pseudo seizures, pseudo seizures or non-epileptic kind of seizures, pseudo seizures. So there could be some kind of a psychological conflict or stress which is happening, which is leading to this kind of conversion reaction. So what is the treatment you give? Please remember, ketogenic diet is useful in resistant seizure disorder. In children, especially in resistant seizure disorder, it is useful, ketogenic diet. Of course, valproate is an anti-epileptic which is used. It can also be used as mood stabilizer, but here we are talking about valproate being used as anti-epileptic. Initiation of aversion therapy. See, aversion therapy is used in alcohol withdrawal. Alcohol withdrawal using disulfiram is called as aversion therapy. So that's a entirely different condition. Here, what we do is maybe behavioral therapy. More specifically, they should have given CBT, cognitive behavioral therapy would be a better choice at the given. So what do you do in patients with pseudo seizures? You would like to identify what is the conflict, what is happening, and help them to deal with their stress in better, healthy coping manners. Thereby, the attacks might come down. In relation to this question, it's also good to know the difference between true seizures, true seizures, and pseudo seizures. It is good to know the difference between true seizures and pseudo seizures. Please remember, true seizures can happen at any time, any place, in the presence of any person. Pseudo seizures generally happens in the daytime, in the presence of known people, as also given in the MCQ question. Understood? True seizures mostly are stereotypical. Means what? Every attack will be similar, whereas pseudo seizures can be of changing or variations in attacks. So once they will move the right hand, once they'll move the left hand, one they move both the legs, once they'll not move any hands and legs. Such kind of different episodes can happen. Tongue bite can be seen in true seizures. Incontinence can happen in true seizures. The tongue bite and incontinence is generally not seen in pseudo seizures. What is very commonly seen in true seizures? Other than this, you can see upgoing plantar response. Upgoing plantars are very common in true seizures, whereas the plantars are downgoing in pseudo seizures. Increase in prolactin levels. Increase in prolactin levels are very common issue in true seizures, whereas in pseudo seizures there is normal prolactin levels. There is normal prolactin levels. When you take the post ictal EEG, there will be a kind of slowing of waves of EEG. There will be a kind of slowing of waves of EEG in the post-ictal period, whereas here it remains normal EEG after that episode. After the episode, the EEG will immediately become normal, whereas in true seizures, there will be some kind of slowing after the attack. A post-ictal slowing will be seen. So this is an important chart for you to know. Especially don't forget about increase in prolactin levels, upgoing plantars, because that is also something which they have asked in exam, which are very indicative of a true seizure. If a child with ADHD goes untreated into adolescence, what is he most likely to develop? Understood? What is he most likely to develop? Please remember, ADHD is more common in boys. ADHD is more common in boys. as given in the MCQ also. What can happen? ADHD is a condition, if it is not diagnosed and treated, as years go by, many of the patients will improve by themselves, at least in hyperactivity. The hyperactivity will start coming down as age progresses, most of the times. Understood? What remains is attention issues for sure, will remain as an adult also. Impulsivity will also remain to some extent in these patients, but attention issues will commonly remain for larger number of patients. Now, what kind of conditions are comorbid in ADHD patients? Please understand, if a child has ADHD, as they go on, initially they are known to develop ODD. What is ODD? Oppositional defiant disorder. Once they grow into adolescence, they can develop conduct disorder. They can also go on to develop antisocial personality disorder, anxiety disorder, substance use disorder, mood disorder. These are all common challenges which can happen in these patients. These are all common challenges which can happen in these patients. In this question, what they have asked, the best answer would be conduct disorder. Conduct disorder. So, how do you diagnose conduct disorder in a child? Generally, the child of conduct disorder will be anywhere between 10 and 18 years, and they'll have conduct problems, behavioral problems, right? What kind of conduct problems? They can have, they can be deceitful, they can be manipulative, deceitful, they can be destructive. They can be destructive. They are also known to be defiant. They are also known to be defiant. This is how conduct disorder patients typically will be. These kind of symptoms should last for more than 6 months duration. Then only you diagnose them to have conduct disorder, which is quite common in a lot of patients with ADHD. As they age, they can have ODD, they can have CD, they can have ASPD. Of course, they can have anxiety disorders, substance use disorders, mood disorders as an adult. Coming to the last question in this section, we are talking about a 19-year-old presented with to the psychiatry OPD. He has a charming persona. He is behaving well in front of the interviewers. His mother complains of him getting into fights and bunking classes, drinking alcohol, getting involved into police cases. So, what kind of personality disorder does he have is the question. So, answer for this question is antisocial personality disorder. Please remember, antisocial personality disorder is diagnosed when somebody is 18 and above years, then only you diagnose antisocial personality disorder. Moreover, what are the important things you see in antisocial personality disorder? They are antisocial, means what? They get involved in legal problems. They get involved in legal problems, drug trafficking, child trafficking, attempt to murder. Such kind of behaviors are very common in this people. They tend to be very irresponsible. They tend to be very, very impulsive. They don't have any remorse. Even if they do anything wrong, they would not feel guilty or sorry about it. That's very common in them. They can be sometimes showing charisma of their personality and trying to manipulate people. They can tell deviant stories to make you trust and believe them and then cheat you. Those are very common things which happens in anti-social personality disorder people. They basically lack empathy. They are not able to feel the pain of others or understand the emotions of others easily. So they tend to kind of overpower other people and tend to kind of push on other people and get into trouble. A lot of these antisocial personality disorder patients are very commonly known to also have substance use disorder very commonly along with it. Now, in the same question, if it was paranoid personality, how the question would have been? A paranoid personality patient would have been suspicious, not trusting, doubting intentions of others, unwilling to share. That kind of person is paranoid personality. What about narcissistic personality? Narcissistic people are the people who have too much of self love. They have too much of self love. They love themselves so much and they believe themselves so much that they don't listen to anybody else. They can be dictators, they can be very, very strong in confidence, and they are very manipulative in order to get their way going. That kind of people. So, some of the traits of antisocial go along with narcissistic, but what makes antisocial is they tend to get into a lot of legal problems and other things because they have disregard for kind of law of the land. They have disregard for others emotions and those things. That is what makes antisocial little more different from narcissistic. What about schizotypal? Schizotypal people are the people who are really, really odd and eccentric in nature. And eccentric in nature, please remember, schizotypal people are the most are the personality disorder people who are most prone to develop schizophrenia. Schizophrenia. With this, we come to the end of this session where we have discussed some of the important recall questions in psychiatry. Thank you very much for your patient listening. Best wishes for your next exams.